It looks like everybody's been served, so we're going to go ahead and get things started. Thank you so much for coming. I just want to go a little off script. I know my boss back there is probably like, oh no, don't do this. But I just wanted to say, this week I went to a United Way presentation. And then today, driving here, I was feeling good about a bunch of women coming here together to socialize, to shop from some of the vendors. And there's just a lot of positivity this week that I've been in and with and around. And I thought, you know what? Us women today, we need to do what makes us happy. We need to find that happy spot. And then I was driving here from Williamsfield, from South County, and I saw a house that had their Christmas lights on, and they even went as far as to plug in their Christmas inflatables and had them blow up outside. And I thought to myself, well, you know, it's February. I've never seen that. And then I thought, you know what? I bet you that lady has decided I'm going to make myself happy today, and I'm going to plug in my Christmas lights. I'm going to plug in my inflatables. She's probably made a cup of coffee, or maybe she's having an early glass of wine. I don't know. Sitting on the couch, maybe watching some Hallmark movies. And I thought, props to her. Good for her. Right? That's what we all need to do. If we want to go home and plug in the Christmas lights, let's do that, right? So I hope that you find a little joy today, and I hope that there's some vendors that have some things and your friends here that make you happy. So thank you for coming. Welcome to ACMC's 16th Annual Luncheon. I'm going to put on my cheaters, and I'm going to tell you this is not going to help me say cardiovascular when I read this, because I've stumbled over that several times when I tried to practice this. So after the past few years canceling this event and then bringing you a remote heart luncheon, it's nice to see your smiling faces here. A lot of you are wearing your red, and you look absolutely beautiful. Thank you so much for coming out. I'm delighted to be part of this and bringing this to you. It's such an important health topic. As I've said, this is ACMC's 16th year. We do this because a healthy heart is essential to your overall good health. Helping you embrace a healthy heart and keeping you informed is why we're here today. But I'm going to be honest with you, I am not medically inclined at all. My children were lucky to get a Band-Aid put on straight when they were little. My daughter's here today, and she can probably tell you that they got to a point where they're like, Mom, just give me the Band-Aid, I'll do it myself. But I can tell you is heart disease is the #1 leading cause of death for both men and women worldwide. I also know that cardiovascular disease kills more women than all forms of cancer combined. I know these facts because I've come here and I've listened to the physicians talk and give us great health information. I've learned those facts here. But, you know, I come here and I learned that it might be a little too late for me to get the Band-Aids put on straight, but I'm still going to continue to come here every year and listen to Dr. Al-Assaad today and learn something new. I have the honor of introducing Dr. Al-Assaad, who is a clinic cardiologist. Dr. Al-Assaad has more than 25 years experience in general cardiovascular medicine and more than a decade of experience in interventional cardiovascular medicine. I'm doing pretty good saying cardiovascular so far, right? He is board certified in internal medicine, cardiovascular disease, and interventional cardiovascular medicine. Dr. Al-Assaad earned his medical degree at the University of, you can tell me if I said this wrong, Aleppo. Thank you, Dr. Al-Assaad. School of Medicine. He completed his internship in the internal medicine residency at Case Western Reserve University Metro Health Medical Center in Cleveland. Dr. Al-Assaad received his specialty training through a separate fellowship in vascular medicine and cardiology at Lahey, thank you, Hospital and Medical Center. His subspecialty training as a fellow in internal interventional cardiovascular medicine at the University of Cincinnati. Prior to joining Cleveland Clinic Medical Center in 2018, Dr. Al-Assaad was the Director of Cardiovascular Services at the Cardiac Catheterization Lab at Clinton Memorial Hospital in Wilmington, Ohio. Now that I've just touched on some of Dr. Al-Assaad's education and highlights, I'd like to share with you just a few reviews that our community has shared with us on our internet. I know, Dr. Al-Assaad, I don't know if you've read any of these yet, so surprise. These are some of the things that have come in it's on the Cleveland Clinic website and on our ACMC website. It said, Dr. A and his staff are great. I have the utmost trust in his suggestions and his treatment. I'm totally impressed with Dr. Al-Assaad, a wonderful, caring, and a gentle bedside manner. Another one said, I just love Dr. Al-Assaad and his team who's here with him today at ACMC. And I will be sharing just one more with you. Dr. Al-Assaad was very thorough. He answered all of my questions and relieved my fears and was very courteous and respectful. I would highly recommend him, and I have recommended him to people. Dr. Al-Assaad is awesome. These are the words of the people who live in our community about Dr. Al-Assaad. And this is the physician we have right here to care for you at home. Dr. Al-Assaad, I want to thank you for walking in the Heart Walk with us this year and helping to raise money to bring back to this community for the awareness of heart health. But most of all, I want to thank you for bringing your kind, compassionate care to our community. So when we need it, we're able to stay right here close to home. Thank you for bringing the care that you provide. Without further ado, I'd like to introduce you all to Dr. Al-Assaad.
Thank you, everybody, for making me part of your wonderful Saturday, and thank you for, coming here to listen to the message. I think it's very important. Thank you, Allison, and everybody from ACMC for organizing and putting all this. And this is such a great effort, and I'm honored to be part of it.
Thank you.
Okay. Sorry. All right. And today, this talk is really going to be really low key. Just a few messages about women's heart health. I want to share some information. I want to share how we can do things better, and hopefully we can all learn and benefit from this. Heart disease continues to be the most deadly disease for our country. It is more people die from heart disease than all cancers combined. And this is especially true for women, which is the topic for my talk today. There are some risk factors that are shared for men and women for heart disease, and there are those risk factors that are specific for women. And we're going to talk today all about that. One of the most important risk factors is menopause, and ladies at age 55 considered to start having their risk for heart disease increased, such as the fact that at age 55, ladies have the same risk of men with heart disease at age 45. And the risks increase by 10 years after 10 years, men and women alike. It was felt that the lack of estrogen is one of the most important factors. It has a negative effect on lipid balance, and it causes all the negative things we want from the lipid profile. So the lack of estrogen will decrease your good cholesterol and raise your bad cholesterol, and it also causes, is a part of metabolic syndrome and truncal obesity. Even the risk factors, the regular risk factors for heart disease, such as smoking, diabetes, hypertension, they affect actually women more than they affect men for the causation of like a heart attack. And let alone the other, female-related risk factors. When it comes to presentation with for heart disease, ladies have a different presentation for heart disease than in men. In fact, more than 40% of ladies have what they call atypical presentation, which is not the usual normal chest pain radiating to the arm that we're all familiar with. They could come with nausea, they could come with back pain, they could come with fatigue, they could come with palpitations. So it's very essential and very important to be familiar with the differences in the symptoms, because if doctors are not familiar or patients are not familiar, that is going to really lead to a delay in the care and lead to a poorer outcome. One of the other things that is different also between women and men for heart, when it comes to heart disease, is the pathophysiology. More heart attacks in ladies happen because of something called plaque erosion than the usual cause for ladies for heart attacks in men, which is called plaque rupture, which is the main cause for a heart attack. A lot of ladies have different causes for angina, such as coronary spasm, which is not a heart attack or so, but it's spasm of the arteries around the heart that can just cause pain and cause symptoms. There's a very important pathology that affects especially women of childbearing age, which is called spontaneous coronary dissection. And that is primarily caused by increased estrogen. It makes the coronary arteries a little more elastic and more prone to develop spontaneous dissection. This happens, unfortunately, in times where there is like increased pressure, such as at delivery time, such as things like that. And a lot of ladies have symptomatic heart disease, but the arteries of the heart are not completely blocked off. They are less than normal. So then what do we do to really diagnose heart disease in ladies with special attention to female that is going to be a little different than men? Everybody knows everybody goes through a stress test. Well, guess what? 60% of women have heart disease from arteries that are not completely blocked off to show on a stress test. So the stress test, where it's about 80% reliable, it's a lot less reliable for ladies. So in this way, you have to rely on other tools such as counting for the coronary calcium in the coronary arteries, such as different other tests called like a PET scan or an MRI or many other tools to just come up with a diagnosis. It's always a little, whenever I have truly a lady at my office that comes with heart disease, I always try not to stop if I get just a negative answer, but something inside me just says, you know, that there is more to be learned from other testing that needs to be done. So that's truly very, very important. I just want to run through some of the differences actually in presentations, and the data had shown that I thought it would be really important to share. Whenever men and women, when we compare men and women having a heart attack, the research have shown that women always have a little longer time to have the artery wide open up with angioplasty and stent. This difference is actually can be up to about 5 minutes, and that's crucial, that's important. It's 75 minutes in men and 80 minutes in women. There is research also have shown that ladies have a 30 minutes additional delay time in presentation coming to the hospital with, you know, because of heart disease. That can be from, you know, truly the lack of recognition of the unusual symptoms that they usually, you know, present with. You know, someone who may present with a backache, somebody who may present with, you know, heartburn, might not necessarily, this might not, you know, be alarming enough for her to come into the hospital earlier and, you know, find out that actually, you know, it actually is, you know, a heart attack or angina or, you know, something that needs immediate attention. Women who actually have even, we find that they have heart disease, less of them actually end up with having stents and balloons compared with men. A lot of women, you know, are treated more medically than interventionally, and that actually leads to less control of symptoms and less control of, now, angioplasties and stent, they don't really, they're not primarily to like save lives or anything. Primarily they are for control of symptoms and quick relief of pain. In situations of a heart attack, of course, they are life-saving, but when we are dealing with chronic heart disease, it's primarily just for you know, symptom control. There's actually a lot of you know, other key points that I think are worth sharing. Even ladies, when they are referred for open heart surgeries, research have shown that ladies are less than men to receive an arterial bypass graft, which is called left internal mammary, and that's the key benefit for bypass surgery because it stays open longer. The internal mammary artery stays open, you know, more than 15 years, and it is found that actually statistically significant, less women get a mammary graft compared with men. And that's very, very important. When it comes to even just medical therapy, less women are at goal with cholesterol, less women are at goal with weight, with exercise, with high blood pressure. At discharge from hospital, less women are on guideline therapies such as statins, aspirin, beta blockers, ACE inhibitors. So these truly are true findings, and they're things that really need to be addressed if we really are looking for improvement of the care, if we're looking for an improvement in the outcome. These are things that definitely need to be addressed. Women are, when it comes to even after a heart attack, after open heart surgery, people are usually referred to cardiac rehab. And research have also shown that ladies are less likely to be referred for cardiac rehab, less likely than men to adhere to cardiac rehab, less likely than men to graduate from the full program of cardiac rehab, and less likely to be able to, for themselves, access cardiac rehab, either for transportation or family issues, or they know they have to get it, but they have other responsibilities that unfortunately they cannot get out of, and us men always are, I don't know.
You can get out of it.
It's the truth, it's the honest truth. Even when it comes to mortality with cardiac care, like for example, after a heart attack, mortality for men and women is the same, but after 1 year, more women are hospitalized than men. More women are hospitalized with heart failure. More women are hospitalized for uncontrolled symptoms. So this is truly a problem that it seems to be one way or the other. Ladies are not getting, I'm not going to say they're not getting the same care, but they're definitely not coming up with the same results. And we really all have to, all work together to, make a change. And so how we make a change is really, really very interesting. And how things become different is really multifactorial and multifaceted. So one of the things that, was felt to be very important is to raise the public's awareness for, that women's heart disease and women's health is actually a true thing. You cannot just extrapolate what happens with men just to, women, because they truly are different. We know you're truly different. So one of the things that has happened, and I think this is very important, and this is why we're all here, is the Red Dress campaign. Red Dress campaign, since it was inaugurated a few years ago, there has been a significant improvement in the awareness to heart disease in women. This awareness has risen from 30% to about 55%. So a lot more people, a lot more ladies are aware of the unusual presentations of the heart disease. They pay more attention to the risk factors, to activity. Truly, education is key. So raising public awareness is very, very important. And raising public awareness can take multifacets, one of which is like the talk and the gathering we are having today. Public education campaigns. Public education campaigns are very essential and very important, and very effective. Because there's nothing better than spreading the message in a situation like gathering like this. The other thing that was felt that is really important is tailored messages on social media. Social media is now a very important tool. It's a weapon that I think it's been very, very helpful to spread the message. And truly, ACMC have been truly wonderful for, making campaigns like this today and their website. Excuse me. So one of the other things that can be done, can I just get water? Excuse me. Sorry.
You were ahead of the game.
I am so sorry. I am so sorry, ladies. So, spreading the message is important. Where else can we spread the message? Schools, faith-based, organizations, gyms, community leaders, workplaces, wellness centers. I think all these, collaboration of efforts of all these organizations is essential. Other things that are also important other thing that I think is very, very important is having dedicated research for women's health, women's heart disease. It's not only it's not the same to get results from men and say, okay, we are extrapolating the results to everybody. Research have shown that ladies are very underrepresented in all research. Like in a study that looked into 156 research papers, they found that ladies' participation was about 25%. So that's very, very low, and that definitely needs to change. Then one of the other important things that need to also be changed is training. When people asked doctors, they found that primary care physicians are comfortable 22% to address special women's heart disease issues. Heart doctors were not a lot better, 42%. A lot of, truly, a lot of people who just get out of training feel that about 70% say that they are really not prepared to tackle precisely just ladies' heart disease, questions or so. So the remedy for this is to incorporate special CME hours just for women's health and women's heart disease. Make special sessions in scientific sessions just dedicated for women's heart disease. Make them part of credentialing, make them part of any formal body for education, such as in medical schools, nursing schools, pharmacy schools. That would be a way to, at least spread the message from the grassroots up. Then one of the other things that we touched upon is to definitely include more ladies in research and make them part of more research programs. One of the things that the new pandemic taught us is to incorporate telemedicine, and there's a lot of ladies who are unable because of family situations or family-related issues, and that's especially much more prevalent with minorities, that they are unable to themselves get to care because of them having family responsibilities, taking care of family members, or having constraints in reaching to medical care. So I actually, we've actually started that even at the office, but then I think we've kind of cut back a little bit on that. that we have dedicated slots now that are dedicated to telemedicine. People who just want to have their care through a website or so. That's really very important. This is what COVID had made us change, but I think this is important and should continue definitely for time to come. I think, and having of course flexible hours, maybe having doctor's hours on Saturdays or Sundays. The other thing that I think is very, very important is having a change in legislations and having a change in the rules and regulations, and that requires people working together, doctors, researchers, and people who make decisions, policymakers. And based on that, a lot of actually initiatives came into play. For example, in 2014, the FDA had a new action plan that addressed 27 points pertaining to women's health and heart disease. So there is a lot of things that need to be changed and incorporated in policies. I think all these together will make a change, and this is why it's a long road. But I think it's being started, and I'm very honored to be, with ACMC part of this. And we really thank you for coming, and thank you for being here. Thank you for spending your Saturdays with us, and appreciate it. I'm happy to take any questions.
You have a question here?
Oh, just me?
Yes.
Oh, yes, I was going to say, do you feel like after a certain age, maybe even 70 on ladies, and to say, maybe I come from my mother's side where they have heart problems. I so far haven't had nothing. Only when I go up and down stairs, I huff and puff, but otherwise I'm in good health. But do you feel at a certain age, like past 70, we should go and ask our primary doctor, maybe I should take a test or a stress or something to check on the heart?
That's a very, very important question, and actually we truly get that. I think yes, because there's a lot of, heart disease. Heart disease doesn't start with a heart attack.
Right.
So it starts with things that can be preventable. So I strongly believe that, yes, you should. So either with that being a test, either with that being, maybe, like you control or check your your blood pressure at home multiple times and share it with your doctor, and then for the least hint, definitely be referred for a test. Yes. Yeah.
Is there any research out there showing that there's something different in medicine that could be an alternative to statins? Because I've tried statins, I've tried multiple kinds. Every single one of them makes it so that I can't walk. I have a very difficult time with my leg muscles. So I was just wondering, I'm sure that there's many people out there that have this issue. I was just wondering if there's any new medicine that might be getting tested to replace statins.
So what you are referring to is something called statin myopathy, which is almost like the inflammation of the muscles by statin as a group of treatment. There are alternatives that are now out there, and there is more in the pipeline. There is a medicine called Zetia, and that is not a statin, that can sometimes reduce cholesterol. It's milder, definitely milder than statin, but it is better than not being on anything if you need to have your cholesterol lower. There are many other medications that now are actually injectable, and you can take those every 2 weeks. They're like an injection, like insulin injections, and they're given every 2 weeks, and they have almost zero side effects. They're very clean because they're genetically engineered medications, and their only side effect is if you actually are allergic to the medicine itself, but they don't have actual side effects. The research keeps coming up with new medicines. There are some medicines that are in the pipeline, but not approved yet. You're welcome.
And if you would like the phone number to make an appointment with Dr. Al-Assaad, I can help you with that.
Great marketing.
Our heart
Yes.
problems.
Yes, that's actually the biggest risk factor. That number one, we so far have been unable to change, and it's actually the strongest risk factor. You know, family history of early heart disease and probably diabetes are the two strongest risk factors for heart disease. And I'm sorry, I just have to say one thing. Whatever we said all about heart disease goes along for all the arteries around the body, because you know the risks are the same. The presentations might be different, but you know, like damage to a blood vessel doesn't choose just the heart. If damage is going to happen, it can happen everywhere. So it can happen in the brain, and people will be at risk of stroke. It can happen in the legs, and people can be at risk of what they call claudication, which is pain in the legs when they walk. It can happen in the kidney arteries and cause kidney disease, as well as it can happen in the heart.
My sister had a pacemaker put in this summer after she had surgery because her heart rate had dropped immensely. I come from a family of heart disease. I am a diabetic, and I also have autoimmune issues. Is there a certain test that I should be asking the doctor to be given for myself?
I think I would start with making sure your blood pressure and cholesterol are checked, and if those are normal, and if you have that strong family history for heart disease, I would start with a stress test.
I've never seen a female cardiologist. Why are not more women?
That's actually part of the campaign, is to train more docs and train more people. That should be one of the remedies.
Can you explain a heart murmur?
So a murmur is the sound blood makes when it passes through a turbulent area, such as when you have a little bit of a narrowing of a valve or a little bit of a leak of a valve. Both situations cause when we listen to the heart sound, instead of you hear the regular sound, you hear like a swooshy sound, and that's what the heart murmur is.
How much research backs up the fact that CoQ10 would help when you're taking statins?
You know, that's a very, very good question, and that we really get that a lot. To be honest, I've been in practice for many years. I have not prescribed CoQ10 to anybody. But if people are convinced and they come to me and they are on CoQ10, I don't take them off of it. Its main benefit, I feel, is to the companies that they make it. It's it's a good medicine. It's a good additive. It has no side effects, but the research has shown very little benefit truly.
My sister-in-law's doctor is talking about putting in a Watchman.
Mm-hmm.
Is that different than a defibrillator? What is it here? Where is it?
Yes, a Watchman is a device. It's almost like a sifter. It's almost like an occluder. So it's not. It doesn't have a battery. It doesn't have. It's not a defibrillator. It works as a plug, and it is done in people who they need to be on blood thinners, yet they are at risk of bleeding from blood thinners. They could have either had a bleed in the head or a bad bleed in the GI tract, or they have recurrent falls that they are at risk of bleeding if they fall. So that those people, on one end, you need to protect them against a stroke because they have AFib or an irregular heartbeat. Yet, on the other end, you cannot prescribe blood thinners for them for a particular reason. So the Watchman is now what is the solution for that, is that you protect them against, having, a stroke, yet you don't really subject them to increased risk of bleeding. It's not prescribed for everybody. You have to have, for example, you cannot say, I cannot afford the medicine, that's why I need a Watchman. You have to have a medical indication, such as the bleeding or the falls, or to be able.
So she gets a lot of fluid. Whenever her heart's acting up, she has to go on Lasix and stuff.
Mm-hmm.
And they do have her on a blood thinner now.
So she must have that irregular heartbeat, the AFib.
Yes.
But there is, on top of that, they may have noted that she's anemic, and they can't find out where's the source of her bleeding or something. There has to be a bleeding risk in the background.
Okay, thank you.
Welcome.
So are you saying that the Watchman is a sifter? Is that to catch any blood clots?
Mm-hmm. It holds them in a little tiny chamber in the heart. It's called the left atrial appendage. That's where blood clots usually hide and reside before they are propelled and they go upstream and they cause a stroke. So it's the Watchman is installed on the roof of that left atrial appendage, so it kind of seals it, but it allows all liquid blood to pass through, whereas it holds any blood clot behind.
Is there a different risk factor for somebody who might have a genetic high cholesterol or low cholesterol compared to a food or medical reason for high or low cholesterol?
Well, genetics are always, people who have like what we call familial hypercholesterolemia, they're definitely always at risk. And there's actually a lot of people who you'd find them thin, slender, and active, yet their cholesterol is totally out of control. So those people definitely are at risk, and their cholesterol is not determined by either lack of activity or weight or so. It's genetically determined, and they definitely are at risk. Yeah.
I have a pacemaker, but I also have AFib. Do you recommend them with the paddles to get me on an AFib?
So there are two ways to think about AFib. Some people think that every AFib needs to be treated and to try to restore heart rhythm. And for that way, you have to do everything you can, either with defibrillation, or either with medications, or either with even ablation and pacemaker. And there is another school of thought that says, people can live with AFib because, as we all get older, 20%, 10%, or to 15% of the population's rhythm turn into AFib. It's the normal progression of the rhythm. Now, there are many other reasons. That's if you exclude many other reasons for AFib. But if there is nothing else except someone presenting with AFib, it can be just because this is how the rhythm is going to, present as, we all, get a little older or so. So you don't have to, get the person out of AFib. What you really need to do, what is critical, is to control the heart rate, because a heart rate that is under control, people don't really have any feeling that they are in AFib. But a heart rate that is not controlled, people get very easily breathless and they get short of breath or so at the least minimum activity. In those people, you definitely have to control the AFib or restore sinus rhythm.
What is considered a safe range for the resting heart rate? When does it become dangerously low?
So the normal heart rate is anywhere between 60 to 100, normal resting heart rate. 60 to 100 is considered normal. When we go to sleep, our heart rate normally is slower. It can go down to the 40s, and that's normal without any medications or anything. So anything definitely less than 40 is definitely not normal. But usually it's also it's gauged by two things: by the number, the heart rate, but also by the symptoms. For example, if someone's heart rate is normally 50, it can be because they are athletic and they are very well trained. People as such, they have a lower resting heart rate. That's normal. And if people who normally their heart rate is in like 70 and 80, and all of a sudden their heart rate is 40 and they are symptomatic, they are fatigued, very tired, they are breathless if they want to go pick up the mail and come back, those people may actually need a pacemaker. But the baseline heart rate is anywhere between 60 to 100. That's the normal resting heart rate.
Are there any other questions? Dr. Al-Assaad, thank you so much for all of your time.
Thank you, Allison. Thank you, everybody, for being here. And thank you, and Happy New Year, Happy Red Dress campaign. Thank you for putting all this together. I truly appreciate making me part of your day.
Thank you.
Thank you.